The basic evaluation for Hodgkin lymphoma in the developed world is basic chemistries, a complete blood count, creatinine, LDH. Generally, people would get a CT chest, bone marrow evaluation, abdominal and pelvic CT, and PET scan. I'm sort of thinking about how that would translate to here. I think you could still treat a lot of people very satisfactorily without all this, but I think these things help. So staging, stage 1 is a single lymph node or a limited involvement of a single extra-lymphatic region. Stage 2 is greater than one lymph node region or limited extra-lymphatic site, all on one side of the diaphragm. Stage 3 is limited disease on both sides of the diaphragm, and stage 4 is extensive disease. It's a little bit more detailed than that, but those are the most important highlights of staging. And then we talk about B symptoms also. Fever, sweats, or weight loss constitute B symptoms. So pathology is extremely detailed, and very few people have it mastered. They're all pathologists, but basically, if you know a few of the major kinds of lymphoma, you'll be able to treat about 80% of your patients. So I think about most lymphomas as either being indolent or more aggressive. So indolent lymphomas include follicular lymphoma grade 1, follicular lymphoma grade 2, and malt and marginal zone lymphomas. Examples of more aggressive lymphomas, sort of the prototypical more aggressive lymphoma is diffuse large B-cell lymphoma, and then also follicular lymphoma grade 3 would be another example of a more aggressive lymphoma. When you do the staging, about 20 to 30% of people with follicular lymphoma will have early stage disease. Most people with malt lymphomas will have stage 1 or 2 disease. And about half of people with diffuse large B-cell lymphoma will have early stage disease. The other half will have stage 3 or stage 4. So I think about treatment of non-Hodgkin lymphoma in terms of 3 major things. I think about what the dose should be, number 1. Number 2, I think about what the field should be. And then I think about how and or if and how our treatment with radiation should be combined with chemotherapy. So for dose, this study was published a few years ago in Radiotherapy and Oncology. It's a, I apologize, I think it was published in Lancet. I think that's the wrong reference. It was a randomized clinical trial comparing 24 gray in 12 fractions versus 40 to 45 gray in 20 to 23 fractions. And every measure of patient benefit was essentially identical. I'm showing here freedom from local progression, so radiation oncologists are always interested in local control since we have a fundamentally, at least usually, local modality, and that's a very important measure of patient benefit for us. And you can see that going out even to 10 years, the lower dose was absolutely as effective as the higher dose. And the same was true for other measures of patient benefit that I haven't shown here, including survival. This is the same study wherein for patients with more aggressive lymphomas received on the low dose arm, received 30 gray and 15 fractions instead of 24 gray. The high dose arm was identical. And you can see, again, freedom from local progression was absolutely identical for the lower dose arm. So the first conclusion is that for people, we used to think that people with non-Hodgkin lymphoma really needed needed doses in the order of 30 to 40 gray or even higher. What now has become very clear is that people with indolent lymphomas can be treated with much shorter courses, 24 gray and 12 fractions. In my own practice, if it's in a non-sensitive site on the body, if it's something in the axilla perhaps, I'll even go faster. I'll go 24 gray in 8 fractions just to decrease the cost to the patient and increase convenience for the patient. If it's in a sensitive area like a conjunctival lymphoma, if it's in a sensitive area like a conjunctival lymphoma, I'll stay with the lower fraction size of 2 gray per fraction. Now, just within the past few weeks, there's been another randomized clinical trial, which I think really fine-tunes our knowledge of dose in indolent lymphomas. And this was a randomized clinical trial comparing 24 gray and 12 fractions, so the dose that was established from the one that I just talked about, and just 4 gray and 2 fractions, 2 treatments, and you're done. And these are the results. So this is local control. This study was stopped early by the data monitoring committee, so when randomized clinical trials are done, there's a separate, from the study team, there's a data monitoring committee which monitors the results as they come in. You know, it wouldn't necessarily, in many clinical trials, it wouldn't necessarily be ethical to continue to randomly allocate patients to treatment if there is information that would suggest that one of the treatment arms is more beneficial. So that's exactly what happened with this study. That's exactly what happened with this study. The data monitoring committee said that the results are dramatically in favor of the patients receiving the higher dose treatment, and they stopped the study, and these are the results in regard to local control. What's interesting about this is that I think, at least for me, and I've actually talked to a number of, I talked to Andrea Eng recently, just a couple weeks ago. She's from Dana-Farber and is kind of one of the up-and-coming leading lights in our field in radiation oncology. This may be the only clinical trial that I've ever known where the data monitoring committee stopped the study early, which actually makes a case in some patients for using the lower dose arm, for using the putatively or what appears to be the inferior arm. And here's what I mean by that. Even the so-called worse arm, and it is worse, isn't that bad. I mean, you're still controlling the majority of patients. So let me give you a case example of a patient that I saw last week, about a month ago actually, where I chose to use the lower dose arm. So I saw a 20-year-old young man, and he had follicular lymphoma grade 1 of the conjunctiva, and the lesion had been completely removed by the biopsy. So he didn't have a cancer operation. It's very likely that there were still lymphoma cells there, but there wasn't anything that you could see on any kind of imaging study. You couldn't see it on exam or anything like that. And I thought to myself, this young man has, you know, perhaps 60, 70 years or more of life to suffer the negative consequences of a higher dose of radiation. So I actually showed him these curves, and we had, together with his family, we had a fairly long discussion about, you know, whether we would go with this little bit, you know, meaningfully higher local control, or whether we would just use the lower dose arm, recognizing that if that fails, you probably haven't lost anything. You can still come back and treat with a higher dose. And after a pretty heartfelt discussion, this young man and his family actually chose this lower dose arm. And I actually think that that's pretty reasonable. You can still get treating conjunctival lymphoma even with 24 gray and 12 fractions. I've actually treated a fair amount of that, and a fair number of patients, I would say, well over 50%, end up with at least some minor dry eye syndrome. And so you can potentially avoid that by going with the lower dose arm. That's not going to have any adverse effects that can be meaningfully measured, at least within the following few years. And one of the reasons I'm comfortable doing that in selected patients is that this is the survival curve. So even though the lower dose arm resulted in inferior local control, it didn't make any difference whatsoever in survival. These should probably be ignored. This is based on about 2 or 3 patients, and the numbers really aren't very statistically meaningful out here. But before you, on the statistically meaningful part of the curve, there was no suggestion that the lower dose arm was resulting in an inferior outcome in terms of actually survival. I think that might be particularly pertinent also. I mean, I think we all have to be wary of resources and how we use them. You know, I think in our country, short courses are vastly, vastly underutilized. We should all be using 8 gray and 1 fraction for bone metastases, for example, as our standard of care. There may be rare exceptions where you can justify a longer course, but usually not. Despite that, longer courses are typically used. But I think particularly if resources are scarce, and they always are, it's just the degree of how much they are, shorter courses might make a lot of sense, recognizing that if treatment fails, you can still come back and retreat the patient with a higher dose of radiation. The other thing about this study was that 60% of the patients on this study had stage 1 and 2 disease. So this is, the data definitely applies to patients with early stage disease. Okay, to summarize then, in a phase 3 study, randomized study, 24 gray resulted in similar outcome compared to 40 gray with indolent lymphomas. In the same study, a dose of 30 gray resulted in similar outcome when compared to doses of 40 gray or higher. And in the last study that I mentioned, 4 gray and 2 fractions resulted in lower local control compared with a higher dose. But as I've tried to convince you, there may be cases where a lower dose is still appropriate for highly selected patients. Okay, what about field design? Field design I can deal with very quickly. All you need to do is use a very localized field. And that's really based on a number of studies. I've listed 3 here. These are in patients with large cell lymphoma using so-called involved node radiation, so just treating the nodal area of disease with sufficient margin to make sure you get adequate dose. And you can see that that results in very low local and marginal recurrence rates. Here's the same data for patients with more indolent disease, only a 1% local regional recurrence rate in patients treated with very limited radiation fields. And that's really the most important thing that you need to know about field design in radiation therapy for lymphoma. So in terms of extent of radiation, limited fields are appropriate. The term involved node radiation is used widely in the North America. A slightly expanded concept is something that some of my colleagues who are leaders in the field refer to as involved site radiation, which is just expanding the field just enough to be absolutely sure that you're not actually missing the tumor. Okay. So indolent lymphomas, we want to use stage 1 or 2. For stage 1 and 2, we want to use limited field radiation. This is the kind of result that achieves in terms of long-term survival. Just to briefly mention, there is another lymphoma which tends to have behaviors that share some behaviors of the more aggressive lymphomas and some behaviors that are similar to more indolent lymphomas. It's called mantle cell lymphoma. They almost never present with early stage disease, but occasionally they do. I think I've seen 2 in my career. And this is just a survival curve showing that it is possible in those patients very rare patients who present with early stage disease. This is radiation therapy as a component of the patient's overall treatment, resulting in about 40% long-term survival. So generally, patients with indolent lymphomas who have stage 3 and 4 disease are not curable, but they can live a long time. 10, 20 years even sometimes. And you can observe them initially with no treatment, or you can treat them with palliative radiation or palliative chemotherapy as appropriate. For more aggressive disease, we want to use chemotherapy followed by radiation in most situations. That is based on this randomized trial. So patients in this study were randomly allocated to receive CHOP chemotherapy, cyclophosphamide, adriamycin, vincristine, and prednisone, with or without radiation. And this is from the landmark article that they published in the New England Journal of Medicine, showing better survival in the patients treated with combined modality therapy, the upper curve compared with chemotherapy alone. Typically, these are, if it's a patient with a B-cell lymphoma, since the study came out, the drug rituximab has been shown to also improve outcome. So most patients would get R-CHOP if it's a B-cell lymphoma instead of just CHOP. Patients with stage 3 or 4 disease receive chemotherapy alone. There really is no convincing evidence at all that patients with more advanced disease benefit from radiation as a component of their treatment. There were a series of studies that came out from Mexico that appeared to show that combined modality therapy was of benefit, but actually, and those kind of like were often mentioned for many years as evidence that radiation therapy had a role. Unfortunately, within the last about year, the two of the major articles that supported that were actually retracted from the literature. Those are the Avili studies for my friends who know about that. So, to conclude, 24 grain 12 fractions is sufficient for most indolent lymphomas. In some situations, 4 grain 2 fractions may be appropriate, but it will result in a lower rate of local control. Limited fields are appropriate for both indolent and aggressive lymphomas. To kind of sum it up, stage 1 and 2, radiation alone for indolent lymphomas, stage 3 and 4, observation, palliative radiation or palliative chemotherapy. For aggressive lymphomas, in general, chemotherapy followed by radiation, and for more advanced disease, chemotherapy alone. And I'll just leave you with one additional note. There's a study called the Unfolder trial. It's a randomized clinical trial in Europe that's ongoing. It includes a randomization. It's a complicated study, but among the randomizations in the study is a randomization to receive radiation or not. And the data monitoring committee has closed both of the arms that do not have radiation. You know, that's interesting. I think a lot of people, some people are starting to change their practice based on that, including changing their practice for patients with advanced disease. I think that's premature. And the reason, I think all you have to do is look at the studies from Mexico that I previously mentioned to sort of see the wisdom in waiting until we really see what the data is before coming to that conclusion. And that is all I have. Nick.